I am pleased to next announce and introduce Dr. Sravanthi Madala, who is a dual-boarded endocrinologist at Emerson Hospital. She got her endocrinology fellowship at Brown University. We are thrilled to have her here. She's originally from Acton, so this is home. And I think that all of us share this enjoyment of treating the community that we live in for the most part. So thrilled to invite Dr. Madala to the stage. She's going to be talking to us about bone health.
Thank you for that lovely introduction. I am thrilled to be here today. Before I start, I'd like you all to just stand up for 1 second. Everybody, hands up. Touch your head, shoulders, knees, and toes. One more time. Head, shoulders, knees, toes. Wiggle it out and sit back down. All right, now that our blood is flowing, thanks to Dr. Bute's riveting lecture and on vasomotor and vascular diseases, let's talk about how bones change as we age. I'm an endocrinologist. As an endocrinologist, I treat so many different types of conditions, and I have the utmost privilege of seeing people for decades. Once you're my patient, you're here to stay. So without further ado, let's talk about how bones change as we age. So today I'd like to talk about when our bones undergo significant changes, including their density, strength, and their overall health. And the importance of this is understanding these changes can help in prevention and management of these age-related changes. I'd like to talk you through the understanding of bone health and bone composition, and also give you some pointers and take-home messages that you can implement in your own lives in order to protect your bone health. In order to understand bone structure and function, first we must understand what bones are made out of. So bones are made out of calcium. Calcium provides the hardness we associate with our bones. They also are made out of collagen. Collagen provides flexibility. And within the bone, in the bone marrow, that is our blood cell factory. And between all of these layers, in a dynamic process called bone remodeling, bones are continuously broken down by cells called osteoclasts. The way I remember that is clasts cleave. So osteoclasts break down the bone, and they're built back up by cells called osteoblasts. The way I remember that is blast out bone. And the balance between this osteoclast and osteoblast is really crucial to maintaining overall bone health, which changes as we age. Unfortunately, osteoclasts become more active as our estrogen levels decline and overtake the osteoblast activity. Bones are constantly being broken down and built up. And there are two types of bone that our skeleton is made out of. There's cortical bone, which is 80% of our skeleton. Cortical bone makes up the long bone shafts. Think your thigh bone, your humerus, your long bones in your legs, your tibia and your fibula. And this is a more dense type of bone. Then there's the trabecular bone, which is spongy bone. And this type of bone is found along the edges of the bones. So at the ends of the long bones and also in the spine. The spine is mostly spongy bones. So 20% of our skeleton is made out of this spongy bone. And it's less dense than the cortical bone, and it's made up of more of lattice type cells. As we age, our bones undergo changes naturally. When we're born, if you ever have looked at a baby, they're very floppy, very squishy, very cute, but their bones just aren't as strong. But if you notice that graph over there, bone growth grows tremendously. The density of bone goes up as we age, and it peaks in our 20s, fortunately and unfortunately. And as we enter our 30s, bone mass gradually starts to decline in everybody. This is a critical change, especially for women, because in women, after the peak, as that bone mass declines, especially in that post-menopausal stage or that perimenopausal stage, that is when estrogen levels decline precipitously. And that is the time in which the bone loss also accelerates rapidly. And this makes postmenopausal women especially at higher risk and vulnerable to osteoporosis, osteopenia, and bone fractures. The areas most commonly affected include the spine, the hips, the wrists, and fractures are growingly becoming a more prominent concern for females. And estrogen and testosterone are both key factors in this. Estrogen in females and testosterone more in males. Estrogen and testosterone help maintain bone mass by inhibiting bone resorption. So that's the osteoclast. It makes them less active. And a sharp decline in estrogen gives those cells a time to go and party, so they eat up more of your bone. And in men, this process is slower, but it still happens in men as well, especially after the age of 70. So, like I mentioned, as we age, our bone resorption outpaces bone formation. And this leads to weaker bones, more porous bones, and increases fracture risk. If we take a look at the picture on the left, that is healthy bone. You will notice that the matrix of the bone is thicker, and it's not as holy and not as porous. It's denser. The picture on the right is a bone with osteoporosis. It's much more porous, it's much less dense, and if I were to drop the bone on the left from a height of 2 or 3 steps, it'll probably stay intact. But if I were to drop the bone on the right from that same height, it'll probably shatter. And that, many women don't realize this as they age because osteoporosis is a silent disease. And it doesn't have any symptoms in most people until they fracture something. The conditions that this condition weakens bones. First, as our bones get a little more porous, it's called osteopenia. And this is lower than normal bone density. And as that progresses, eventually it's called osteoporosis, where our risk for fracture is higher than it is with osteopenia. And this is more prevalent in postmenopausal women. So how do we screen for this? With a bone density scan. When do we get a bone density scan? How is it done? Let's talk about it. So in women, the American College of Gynecology, ACOG, the United States Preventive Services Task Force, and the National Osteoporosis Foundation all recommend screening bone densities after the age of 65. Now, women between the ages of 50 and 64 should also get a bone density if they have other significant risk factors. And we'll talk about that in just a second. Men should also get screened for osteoporosis after the age of 70, or if they too have significant risk factors. Bone density scans typically take 10 to 30 minutes, and we have multiple centers at Emerson that offer bone density scanning. And the radiation dose that you receive from a bone density scan is only about 1/10 of that from a regular chest x-ray, so very little radiation. It's a simplified x-ray. And it takes measurements of your spine, your hip, and your femur, which is your thigh bone, and sometimes of your forearm. Forearm measurements are typically done if we cannot get a good measurement of the spine because of previous fractures, or if we can't get a good measurement of the hip because of a hip replacement. And it measures the strength and mineral content of your bones. And how does that measurement take into effect? So when we look at a bone density scan, we look at what's called a T-score. A T-score is a standard deviation. It compares your bones with that of average peak bone mass. So basically, a long time ago, someone took up thousands and thousands of 30-year-old white female bones at the peak of their bone mass and came up with a lot of data. And these bone density scans measure our bones corrected for race, age, and ethnicity to those bones with peak bone mass. And if your standard deviation is 0 to negative 0.9, that's still normal. That's within one standard deviation from the average. -1 to -2.4 is considered osteopenia, and -2.5 and lower is considered osteoporosis. So what are some of these risk factors? And these are really important. Some of these we can change. These are our modifiable risk factors. And others we may not be able to change, but are still really important to know so you can identify your own risks. Lifestyle changes are crucial for maintaining long-term bone health. And things such as smoking, vaping, nicotine use, cannabis use, they all impair calcium absorption into our bones, while excessive alcohol can reduce bone formation. More than 2 drinks a day for women, according to most of the data, and more than 3 for men, decrease bone formation. The newer data suggests that even 1 drink a day, so average of 7 drinks a week, can be deleterious to our health. And caffeine is another thing that has controversial data out there, but excessive caffeine intake, more than 600 to 800 milligrams per day, that's about 3 to 4 cups of coffee, which some of us drink, but it's important to keep in the back of our minds as we add up all of these risk factors that we already have in our lives. Increased caffeine can have increased bone resorption. So 1 cup of black coffee, for reference, is about 180 milligrams of caffeine. If you're going to drink a cup of coffee, drink a cappuccino with lots of milk. Quitting or reducing these habits is key to preserving bone strength. And limitation of any of these, anything in moderation, is key to understanding that as well. I will talk about activity and calcium and vitamin D in future slides, but I'd like to shift your focus over to the other side of the screen. And these risk factors sometimes cannot be changed. There are non-modifiable risk factors, such as race. Females of Caucasian and Asian origin are at higher risk for osteoporosis. Gender, females are at greater risk than males. And menopausal status, like we know. Body habitus, being too thin or having obesity, both put us at risk for osteoporosis. Our fat cells hold on to an enzyme called aromatase, and aromatase holds on to estrogen. So in our postmenopausal years, if we have more adipose cells, we hold on to that estrogen a little bit longer, but also being overweight or obese puts us at risk for high blood pressure, heart disease, diabetes, which are all independent risk factors for osteoporosis. There are certain medications that can increase bone resorption, so the bone breakdown. And some of these include certain cancer treatments, some acid reflux medications, seizure, epilepsy meds, and the most prominent of all is long-term steroid use, especially oral steroids. Now, some of these you may not be able to stop. You may have a condition for which you have to take an acid reflux medication for life. And if you cannot stop it, at least you will know that this may put you at risk for osteoporosis. Our family history is also really important. If you have a first-degree relative or a parent with osteoporosis or a history of a hip fracture, then that puts you at higher risk for developing it. Other disorders, such as eating disorders, which may have prevented us from getting the nutrition we may have needed in our teenage years, or other rheumatologic diseases, other psychiatric diseases and psychiatric medications, kidney disease, and some autoimmune disease, among many more, can increase our risk. There are a lot of things that increase our risk, but it's good to be knowledgeable about them. While it's nice to be ignorant, ignorance is bliss, knowledge is power. And if you have a history of poor absorption, such as celiac disease, Crohn's disease, ulcerative colitis, these conditions prevent our gut from being able to absorb proper nutrients. That also puts us at risk. And of course, any type of gait instability, if you have a neurologic condition that puts you at risk for falling, falls increase risks. And so when a bone density is done, it takes into account, if any of you have had a bone density scan done, you may have had to fill out a questionnaire about all these risk factors. It takes into account all these risk factors and gives us a better scoring system to be able to tell who is at higher risk. This scoring system is more useful for those with osteopenia, not quite osteoporosis, because it tells us which of these risk factors are modifiable, non-modifiable, and who we need to treat sooner. So how do we keep our bones strong? Maintaining strong bones requires both nutritional and physical strategies. Women should aim for about 1,200 milligrams of calcium through food and supplements per day, and ensure that you are getting enough adequate vitamin D per day, which is essential for calcium absorption. The Endocrine Society just came out with new guidelines over the summer, just saying everybody should take vitamin D. Don't even check your levels, because it is so important and so prevalent to preventing so many of these things. 1,000 international units a day is typically what is recommended, although many people, especially those of us that live in the Northeast, need much more than that. Along with nutrition, weight-bearing exercises such as walking, yoga, strength training, resistance training are all very important. These activities stimulate bones to grow and help maintain bone density, especially as we age. Prioritizing these habits early on is key to long-term bone health. Yep. So let's talk about some of the dietary sources. Who here remembers the Got Milk campaign from the 90s? Right? Because while it was great advertising, the campaign eventually fizzled out. Because why? While the campaign was meant to be memorable and entertaining, it didn't define how it would measure success. And getting people to laugh about milk isn't the same as getting people to buy it and drink it. And now there's so much lactose intolerance, and many people cannot tolerate cow's milk. And also in the 90s, milk got competition from other beverages such as soft drinks, sodas, bottled iced tea, and these beverages were much more funded and received much more advertising and branding. So, and unfortunately, some of the other dietary sources out here can't really say got canned salmon as well as you can got milk. It's not as good of a catchphrase. But how many of us actually listened to our parents when we were younger and drank that milk? I'd like to go on record in front of all 250 of you, including my own mother in the audience, when I say, Mom, you were right. So some of the sources from dairy sources include milk, which has about 300 milligrams of calcium. Yogurt, about 400. Yogurt is a good source of calcium. It has great probiotics too. Cheese, and then we have our greens, kale, spinach, collard greens. The thing with the greens is you'd have to eat about 8 cups of cooked spinach to get similar amounts as 1 cup of milk, which is a lot of spinach. Now, not all of us can be Popeye, but we can try. And then there are the fortified plant milks, the fortified juices, the breakfast cereals, the canned salmon, sardines, nuts, seeds, and white beans. And then we have our calcium supplements. So the main sources of calcium from supplements are calcium carbonate and calcium citrate. Now there's a sheet out at the front on one of the tables that you can get with all the dietary sources of calcium listed on the front and all the supplements listed on the back that you can take home and study at your leisure. Calcium carbonate is typically taken with food, and calcium citrate can be with or without food. The absorption depends on that. And you may have seen on social media and on the interwebs some other calcium supplements, people promoting strontium, people promoting all these other things that have gained popularity. All plant-based calciums like AlgaCal and these other things that you might see on social media, they're not really evidence-based. And in medicine, as Dr. Butte has said, we practice evidence-based medicine, things that have been proven over and over again. And so right now, the safest things on the market are the calcium carbonates and the calcium citrates. And the other ones can actually have more side effects. They can cause more nausea and other GI long-term effects that we don't really know about just yet. Next, I'd like to talk about vitamin D. So vitamin D is key to absorbing calcium and bringing it to our bones. And the key sources for vitamin D, this is the only vitamin we can get outside of food and supplements. We can get it from sun. But it's important to note its limitations. Sunlight, especially UVB rays, they hit our skin and they create a cascade of chemical reactions that actually end up making vitamin D. Now, 15 minutes of sunlight without sunscreen is what is typically needed to get your daily dose of vitamin D. But please put on your sunscreen after that. Otherwise, my esteemed colleague, Dr. Alberta, who will be presenting after me, who's one of our dermatologists, will have my head on a pike. And especially in the Northeast, though, the farther we live from the equator, the sun's rays don't hit our skin at the right angle to make that vitamin D, especially as the Earth's axis tilts in the fall and the winter months. So, like I mentioned earlier, the Endocrine Society recommends that everybody take vitamin D. And if you can't get it from the sun, if you have skin tone, if you have more melanin in your skin, you're not going to absorb it whether you stand out in the sun for an hour or 30 hours. So people with more skin tone need to take vitamin D as well. And people with other absorption issues need to take vitamin D. So good sources of vitamin D, some fortified foods, some fortified milks and fortified cereal have it, but the main source is from supplements. Now you can go to Costco or Sam's Club and get a tub full of vitamin D that'll last you the entire year. And for some people it may cause you to reduce, not be as sleepy at night because it does reduce your melatonin levels, so better to take it during the day. The goal is to keep your levels in the normal range, and typically 1,000 to 2,000 international units will get you there. And vitamin D helps absorb calcium. It helps muscles move. It helps nerves carry messages, and it helps your immune system fight off bacteria and viruses. It is really important. I can't stress that enough. And the last thing that is really important that we can change is our protein intake. Everybody should be getting 0.8 to, even better, 1 to 1.2 grams per kilogram of body weight per day. So for example, if you weigh 100 kilograms, you should be getting at least 80 grams of protein. But that's kind of hard to do. We have to really pay attention to what we're eating and make sure we're getting that. And why is protein so important? Bone structure. Protein makes up 50% of bone volume and a third of its mass. It forms the structure that holds the calcium in your bones. Bone growth. Protein increases another hormone called IGF-1, insulin-like growth factor, which stimulates bone growth. Muscle strength. Protein helps keep your muscles strong, which improves balance and reduces the risks for falls. Falls can lead to fractures, as we discussed, which is a concern for people with osteoporosis. And calcium absorption. Higher protein diets can increase calcium absorption and retention. Now this next slide I could talk about for probably an hour, so I'll try to keep it to under a minute if I can. Not everybody can reverse or improve their bone density with just the lifestyle measurements alone. Many people may need medications and medical treatment based on your risks and other things that might be affecting your bones. There are a few osteoporosis medications out there. There are two categories. There are the anti-resorptives and the anabolics. The anti-resorptives slow down bone loss and they prevent fractures. Think of it as protection for your bones. While the anabolics, they actually build up your bone. So some of the main anti-resorptive medications that you may have heard of are the bisphosphonates. You have your Fosamax, Boniva, Actonel, which are all pills that you take, versus Reclast, which is an IV infusion that's given once a year. Now, how these bisphosphonates work is, I like to tell people, think of it as a coat of armor. It coats your bones and prevents the cells, those osteoclasts, that are overactive in osteoporosis, from getting to the bone and breaking it up. In turn, giving you a chance to build up your own bone with all the lifestyle modifications we talked about. There is Prolia, which is denosumab. It is a once every 6-month injection. End goal is the same as the bisphosphonates, but it gets there a different way. How the Prolia works is it kills the cells that break down the bone. Those pesky osteoclasts, it keeps them at bay. And then there are our selective estrogen receptor modulators, Evista. And our bones have estrogen receptors, and breast tissue also has estrogen receptors. And these drugs help, they imitate estrogen. It's not estrogen, but it imitates estrogen and tricks our bones into thinking there's estrogen floating around. And now this is only good for the spine. It doesn't work for anybody with hip osteoporosis. So it's second-line treatment, but it is an alternative for people that can't take anything else. And it is not used for people with a history of breast cancer for obvious reasons. And then we have the anabolics. These actively build bone. We have the PTH analogs, which are daily injections such as Tymlos and Forteo, and they stimulate bone formation. And then we have Evinity. Evinity is the newest kid on the block. It is what is known as a sclerostin inhibitor. What is sclerostin? Sclerostin prevents bone growth. So how was sclerostin even found? Up in the Yukon Territory in Canada, somebody decided to study the native population there, and they don't have any sclerostin, and their bones are super duper strong. So some really smart people decided, hey, let's make a drug that inhibits sclerostin. And here we have Evinity. Evinity is a once every month injection for 1 year, after which you have to switch over to the anti-resorptives after that to maintain your bone health. And it has both anti-resorptive and anabolic properties. Now, all drugs have side effects, which is probably what most of you are reading on the internet. Some of these drugs have a less than 1% chance of a jaw infection, which is what the Googles and the interwebs will all have glaringly out there. But it is important to note that you have to take risks and benefits into account, and a lot of times benefits outweigh the risks. And these risks are mitigated by shorter duration, by earlier treatment. And many people on these medications go on what's called a drug holiday after about 5 years of treatment, so that it gives your body a chance to have a holiday from these medications to reduce the risk of side effects. And one thing I do want to point out is you might be asking yourself, why not just give estrogen? If estrogen loss is causing all this, Why not take estrogen? That is because estrogen is not first line because of the risks that outweigh the benefits. As Dr. Butte already mentioned, for those over the age of 60 or more than 10 years out from menopause, estrogen treatment actually has increased risk of breast cancer, stroke, blood clots, and heart disease. So that is why estrogen is not used as a first-line treatment or as a treatment for osteoporosis. I'd like to talk about exercise for a minute, but Crystal is our main person to go to for that. In order to keep our bones strong, we need different types of exercise. Weight-bearing exercise forces you to work against gravity and stimulates bone formation. Examples include walking, dancing, stair climbing. Resistance training helps build muscle and improve bone strength. You have your free weights, resistance bands, weight machines. Balance and stability exercises reduce the risk of falls. So anything like Tai Chi, Pilates, yoga, heel-to-toe walking. And then we have the flexibility exercises, which improve our overall mobility and injury prevention, stretching and gentle yoga. And before you do any of these, safety first. I tell all my patients, please go see a physical therapist. They will do a proper assessment and guide you through the exercises that you should be doing and proper form to do them in so that you don't injure yourself. And physical therapy is a great resource. There are also so many other resources. The Wellness Center at Emerson has osteoporosis fitness classes. If you go to your local senior center or YMCAs or any of your local recreational centers, they all have yoga for osteoporosis, bone building for osteoporosis, bar for osteoporosis. There's so many resources out there. Finally, as we conclude, it's important to remember that age-related bone density change is normal. It is natural, but it can be managed effectively with the right approach. In women, especially postmenopausal women who are at greater risk for osteoporosis, in order to protect our bones, it's important to make sure we have our diet rich in calcium and vitamin D. Stay active with weight-bearing exercises, and be mindful of your lifestyle factors, especially the ones that you can change. Beyond avoiding all the things that are bad for you and doing more of the things that are good for you, it's also critical to review any medications that you're on and see if that can be modified. Some people may need osteoporosis medications to prevent fractures and potentially help build bone. But another thing to take a last note of is your home environment. Make sure you have a mat outside of your tub so you don't slip when you fall out of the shower. Make sure you don't have any rugs that are frayed so you don't trip and fall. And in the winters, when you step out of your car in the Northeast, make sure you step down, not out, so you don't slip and fall. Your bone health is in your hands, and let's all take steps together for a more healthier future. Thank you.
Thank you. That was fantastic.